Thank you, people. We apologize for the small hitches because of the network. We welcome you for our today's presentation. And today we are celebrating the World AIDS Day, which is celebrated on 1st of December. And my name is Sylvester Kivindu, a senior nursing working in HIV prevention unit in Kenyatta National Hospital. I hope you will enjoy our presentation. Welcome. Let me hand over to my colleague to introduce ourselves as we start.
Afternoon, everyone. My name is Caroline Ranera. I work at the youth center. I'm the principal nursing officer, taking care of the young people.
Thank you. So let's start our presentation, and we are going just to take you through the overview of knowing what is World AIDS Day, what is HIV, treatment, prevention, HIV in the KNH situation, and talk a bit of people living with HIV, and how is this VCT, and how you can get involved in our work. Yes, the World Day is generally celebrated on the 1st of December, and this is to raise awareness about HIV. So it is a day to show the support for people living with HIV. Remember those who have lost their lives because of HIV, and also to learn the facts and the realities of HIV today in the Kenya and the worldwide. So let's look at the theme of this of World Day, which is 38 since the celebration started, is overcoming disruption and transforming the AIDS response. The overcoming disruption and transforming AIDS response for this day. In 2025, we know there was an historic funding crisis which is threatening to unravel the decades of progress in HIV elimination by 2030. Permanent termination of HIV programs receiving external funding could result to over 6 million additional new HIV infection globally between 2025 and 2026. And this gives us an opportunity to highlight the impact and the funding cuts from international donors, which have raised for us to think about HIV response to AIDS. We need to showcase the resilience of our countries and the communities stepping up to protect the gains made and address the HIV response forward. Next. So, as we understand, HIV is a virus that attacks the body's immune system, and it stands for human immunodeficiency virus, and ACE stands for acquired immunodeficiency syndrome. It is a serious illness that can develop when HIV damages the immune system to such an extent that it can no longer fight off a range of infections it would normally cope with. So let's remember, HIV is not the same as AIDS. AIDS only develops if HIV is left untreated. Let's look at the global estimates, and these are figures for 2024. Globally, the people who are living with HIV are over 40 million, and the people who acquired HIV the same period are 1.3 million, and the ones who are dying from HIV, they are 630,000. With those, the others are those ones who are more than 15 years old. The people who are living with HIV, they are almost 40 million. The people acquiring HIV, they are over 1 million. And the ones who are dying because of HIV virus, they are over 500,000. And when we break the figures down, you can see the women ages of 15 and above. We have 21 million living with HIV. and we have over 530,000 acquiring HIV and over 240,000 dying of HIV. The men also 15 and above years old, we have 18 million living with HIV, 650,000 acquiring HIV, and 320 dying of the same. The children less than 15 years, we have 1.4 million living with HIV, 110,000 those are acquiring HIV, and 75,000 dying of HIV. So this tells us we still have a long way of ending HIV by 2030. And then when you look at the WHO estimates of the same, you can appreciate since the disease started, we have 91.4 million people who have become infected with HIV. And we have 44.1 million people who have died from AIDS-related illness since the start of the epidemic. Yes. So those are the global trends, and you can see from there, the annual number of people newly infected with HIV, which is the blue line. The numbers have been reducing from 1990 towards 2025, and right now we have the ones who are being infected with HIV at 1.3 million as by the year 2025. And the black line shows the ones who are dying of HIV related diseases, and those are 630,000. So we have a global burden because of we have challenges because we have almost 9 million people living with HIV globally in 2024, and they were not receiving treatment. So in the same year, we had an estimated 1.3 million who acquired HIV new infected. So almost the same trend there. And our target for the 2025, we should add less than 500,000 people who are supposed to be acquiring HIV to reduce HIV transmission. When we look at the UNH report, it shows that we were closer than in a decade to ending AIDS by 2030. Yet new infections stayed flat in 2024, as we have seen. And this was even before before funding cuts and the resources were not enough to drive the figures down. And it means we must double down with more strategic actions to drive the real decline of new infections going forward. As we look at that figure, you agree we need everybody's support. Whether you are on top, you are in the middle, we need to join our efforts from top to bottom so that we are able to transform the HIV response and reduce down the infections. So we have our resilience in the HIV response. We have seen there is an emerging global consensus which has been supported by countries, donors, communities, and other stakeholders on the borders of transitioning national response from donor dependence to greater sovereignty and national self-reliance. That is where we should be aiming at. For the HIV response to be sustainable, transformation needs to take place to adequately understand the past 2 decades. That means we have to accelerate our efforts if we really need to put the figures down for the new infection. We should shift our systems, accelerate the integration of the response into health and financial systems, as in incorporating community leadership and the substance. We have to grow domestic revenue mobilization and investments for health and HIV as international resources, so that we have, as the resources decline. When we go down to almost to our thing, you can see globally 45% of all new infections were among women and girls of all ages by last year. So about a quarter of all pregnant women and mothers living with HIV are aged 15 to 24 years globally. And that's also translates to our local situation. So in sub-Saharan Africa, women and girls of all ages account for 63% of all new infections. So you can see we, as a country, we need to do a lot towards that, towards women and young girls. In other geographical areas, about 73% of new infections in 2024 occurred among men and boys. And this means every week, globally, 4,000 adolescent girls and young women aged 15 to 24 years became infected with HIV in 2024. And that 300 of these infections occurred in sub-Saharan Africa. When we come back to our to home, which is Kenya, the World AIDS Day is being celebrated across all 47 counties in our country, with our focus on ending AIDS among adolescent and young people. We know this population group continues to bear a disproportionate burden, facing higher HIV instances and the mortality compounded by the triple threat of new infections, unintended pregnancies, and the sexual and gender-based violence that often result in negative health, economic, and psychological impacts on this population. So Kenya's goal to this World AIDS Day, Kenya's goal is we are focusing on World Day with a theme of one race, one goal of ending AIDS among adolescents and young people. And you can see as we celebrated yesterday, we had a marathon at our national stadium, Kasarani, where we had the race. So HIV burden in Kenya, despite progress, new infections and AIDS-related deaths were recorded, highlighting persistent gaps in prevention, treatment, and care. This underscores the urgent need to strengthen prevention strategies and transmission and sustained treatment access for all. In Kenya, we have some specific information of 2024, and the number of people living with HIV as per 2024 were 1.3 million people. HIV prevalence, the HIV prevalence in Kenya adult population is 3%. Females taking the highest at 4.1%, and males at 2%. HIV acquisition in 2024, we had almost 20,000 people acquiring HIV, with 4,000, that is 22% of those being children, 0 to 14 years. HIV treatment, we have managed to cover 98% of people living with HIV in Kenya are receiving antiretroviral treatment. HIV reduction, Kenya has reduced new HIV infections by 78% over the past decade. So this, we are saying we are having 2,789 estimated new infections, and this translates every week we are having 54 new infections occurring. The overall new infections increased by 19% from 16,752 in 2023 to 19,991 in 2024. So we still have a challenge because we have seen the figures instead of declining, we had a slight increase. And maybe this year, 2025, we might get some increase. The highest increase in new infections was recorded among the adolescents aged between 10 to 19 years, with the cases rising significantly by 34% from 2,000 in 2023 to 2,799 in 2024. And the age-related deaths were 1,137. An estimated age-related deaths every week is around 22 days. There we can see the new infections in Kenya by count, and the highest number of new infections cases in males, like in Nairobi we had 931, Migori 549, Homa Bay, Kisumu following, and Homa Bay and Kakamega. So while the progress has been made in expanding HIV testing and the treatment, sustained efforts are required to reduce new infections. And this means comprehensive prevention programs, timely treatment, and community-level awareness campaigns remain critical to reversing the current trends. So to head the triple threat, Kenya has committed to end the HIV and AIDS as a public health threat and teenage pregnancy by the year 2030, and gender-based violence, including sexual violence, by the year 2026. However, the overlapping challenges of new infections, mistimed pregnancies, and sexual and gender-based violence among adolescents and young people, known as the triple threat, it means the progress towards achieving of the goals. So why are we talking about adolescent and young people? We know Kenya's population is young and is projected to grow steadily and reaching approximately 34 million by the year 2030. So youth aged between 0 to 24 years comprise 59% of 28 million of Kenya's population. So investing in their health and well-being will be critical to economic growth. And the data reveals strong occurrence of new infections in the adolescents, and also with the increase in the gender-based violence. So among the adolescents in Kenya, those are aged between 20 to 24 years, new infections total to over 6,000, with males 1,000, which is 20.5%, and the female being the affected more with the 5,000, which is an equivalent of almost 80%. Those living with HIV, we have a total of 162,000. Males are over 67,000, which is 41.4%. And the females, as you see, they are more than 58.6%. And those who are dying of the related HIV/AIDS, they are 21,000, with the males being taking 49.2%, and the females over 50%. So this means we cannot end AIDS without prioritizing the future generation of these age groups. The adolescent and the pregnancies, 6% of all the pregnancies were among adolescents aged girls between 10 to 19 years. So adolescent girls aged 10 to 19 years accounted for 16% of all first A and C attendees in 2024. meaning we still have a lot of mistimed pregnancies in these age groups. The progressive decline in adolescent pregnancies from 396,000 in 2019 to 240, over 240,000 in 2024. We had some slight decline, but still the burden is with us. Young girls aged 10 to 14 years account for about 4% of all adolescent pregnancies, highlighting the urgent need to protect children from adult sexual activity, exploitation, and its lifelong consequences. Let's look at gender-based violence. Gender-based violence persists as one of the most appalling violations of human rights. It also throws efforts to end AIDS as a public health threat because intimate partner violence is linked with a heightened risk of HIV acquisition among women, and it undermines access to testing and treatment. Globally, 1 in 8 women and girls experience sexual violence before the age of 18 years. And here in Kenyatta National Hospital, this year, from September last year to October this year, we had witnessed 777 cases of gender-based violence, which they have been identified, and 107 were identified as sexual survivors. Among the adolescent girls and the women aged 15 to 49 years, data from population-based surveys from 2020 to 2024 show a median of 18% had recently experienced physical or sexual violence by an intimate partner in East and South Africa countries. For girls and women, intimate partner violence is an nothing common experience which heightens their risk of acquiring HIV. In settings where HIV settings heightens their risk of acquiring HIV setting with a high prevalence rate. The uneven availability and the quality of comprehensive sexuality education puts them and their male peers at an early disadvantage. We need to note for girls and women, staying HIV-free depends on their ability to control their sexual lives and protect their sexual health, neither of which is easy when gender inequalities and discrimination persists, and in access to sexual and reproductive health information and services, including family planning. This is the case especially for women in rural areas and for young and marginalized women. Punitive laws, stigma, discrimination also push these services even further from the reach of the women who need those services. So in Africa, HIV remains a great threat to girls and women, and a great gender equality would change this. Gender inequalities, as we have seen, violence and the gaps in basic HIV prevention programs put adolescent girls and young women at much higher risk of acquiring HIV than their male peers in sub-Saharan Africa. So we are saying, let's fight inequality, beat poverty, and end the HIV infections. So 17,000 represents at 6 of total sexual gender violence cases reported among adolescents aged 10 to 17 years. Reporting of the sexual and gender-based violence among children and adolescents has increased. 78% of all pregnancies due to rape, defilement occur among adolescents aged 10 to 19 years. Defilement is a deeply traumatic experience with a wide range of severe and long-lasting consequences to the girls affected. So The triple threat of new infections, unintended pregnancies, and sexual and gender-based violence drains our national resources and entrenches poverty. So we have the core interventions we need to take. We need to do capacity strengthening of community leaders to champion for prevention and response for where these cases are occurring. We also need to create public awareness and do sensitization campaigns so that we're able to challenge the harmful social and cultural norms and address underlying drivers of the triple threat. National leadership dialogues to secure a high level of commitment and accountability should be enhanced. Adolescent engagement forums, both in and out of school, to amplify youth voices and foster peer-led solutions should be encouraged among these adolescent and young women. Development and dissemination of IEC materials to support behavior change and community education should be encouraged and enforced. When we look at the new infections, when we go down to KNH, Kenyatta National Hospital, you can see our experience there, where the children who are 0 to 9 years from October last year to September 2025 this year, we had 11 cases out of those who are out of 1,333 who were tested. And adolescents between 10 to 19 years, we had 16 new infections out of 1,645 tested. Young people, that is 24 to 24 years, we had new infections of 33 among out of 4,423 tested. 25 to 29 years, the new positives were 51 out of 5,638 tested. And the finger rises as we approach the age of that to 39, where we had new infections of 134 and a positivity rate of 1.5. The ages between 40 to 49, we had new positives of 124 out of 3,119 tested, which is about 4%. Between 50 and 59, the new positives were 86 out of 1,303 tested, and that was highest, giving us a positivity rate of 6.6%. And as we go towards the 60 years plus, we identified 38 positives out of 1,092 were tested. That's giving us a figure of positivity rate of 3.5%. So our burden still remains between, as you can see, from the age of 10 to 19 to around 50 years. That's where we have the biggest burden in the hospital for the new infections. The ones who are put on treatment, the new ones who are identified the HIV positive, you can see our viral suppression in the hospital. Children, they are at 89.1%. They were virally suppressed. Adolescents between 10 and 19, the ones who are put on treatment and virally suppressed, were at 93.1%. And the figures are worrying when you come to the young people. We have challenges there of viral suppression. Can you see we are doing at 90%. Then from 25 to 29, the figures goes up to 93.7%. And then that to 99, it goes, the maximum for viral suppression is between from 40 years and above. We are achieving a viral suppression of 97%, which almost matches with the national figures. When it comes to GBV cases reported in the hospital, and this cuts across the sexual GBV, emotional GBV, and the physical GBV. This one we have not separated. The total survivors are in the blue color, and you can see from the age of 0 to 9 to the age of 20, to the age of 30 or 40, the age of 40, the figures are quite high on the survivors, the ones who surviving the GBV. The sexual survivors are in the is it brown color or is the chocolate color? The orange color. And you can see towards that age group, especially 25 from young people to around the age of that to 39, we have the very high cases of GBV survivors. And the percentage you can see, although it is reducing from the children, all the way is going down as the age increases. Sorry. So from our NCSC profiles from September 2024 to October 2025, those are the cases, the antenatal mothers who, for their first visit to our clinic, and the new positives we are able to identify in these age groups. So from the age of 10 years to 19 years, we do not have any new infections. And those mothers who are at that bracket age group were 24. But you can see the figures are rising when we go to young people, where at the age of 20 to 24, where we had the mothers the ones who were visiting our NC clinic, 245, and we are able to identify 5 new positives. At the age of 25 to 29, we had 500 mothers at that age group, and we had 2 positives. But it is also progress you got from the age that 30 to 39 onwards. We did not have any mother who was new identified positive after being tested. So the roadmap towards boosting the HIV prevention, HIV 25 roadmap developed by the global organization coalition, sets out key actions that can lay the basis for high-impact prevention. So we have to put programs which will ensure availability of proven HIV prevention tools, and most of them, they are the normal common ones, where we are trying to create awareness of usage of condoms, female males medical circumcision, and harm reduction services, and antiviral therapies. Along the new other tools which are coming in, we have the vaginal and oral or long-acting injectable PrEP, which are also in place. So we need to create more awareness so that we can be able to reduce the HIV, the new HIV infections. So the roadmap stresses that HIV prevention services should be delivered along stepped-up efforts to deliver rights-based sexual and reproductive health services and provide good quality secondary education that includes client/patient-centered approaches. So children and adolescents with HIV are losing out in HIV prevention. And this is because mostly we have a lot of stigma, including from ourselves, the healthcare providers. We have also a supportive school environment and the emotional and the behavioral changes associated with adolescence. That makes it difficult for many adolescents living with HIV to remain in care and adherence treatment. And I think we saw from viral suppression in the young people and adolescents, that is where the viral suppression is still a challenge. We have the prevention options, which we are saying you have to stay up to date so that we have to prevent the new infections. We are saying the PrEP works, and we are saying we need a lot of investment in more options, which must continue, and they must be faster. The rollout should be smart and must target the priority populations. Post-exposure prophylaxis PrEP is still an emergency option for people who may have been exposed to HIV. We are saying people need to be encouraged to test, as HIV testing remains an important step in connecting people to prevention and treatment. We are hoping in the future through the new researches, we might have vaccines, which are powerful public health tool and the bedrock of sustainable epidemic control. We know many researchers are going on HIV vaccines and the cure. We are also saying treatment is equal, yield is equal to you. This means undetectable is untransmittable. For those people who stay on treatment and they are consistent in adherence, we have seen the treatment saving a lot of lives, because if they are virally suppressed, the chances of spreading HIV remains almost zero. We also, for voluntary male circumcision, has been shown to work through research and is also a cost-effective approach that could prevent millions of HIV infections. So we need to encourage our populations, especially the males from communities which don't encourage male circumcision, to adopt this kind of method, as we have seen it reduces the chances of HIV prevention through research. We also have all these methods work together in what we call the combination prevention, which should be expanded across all the populations at high risk. We are also having the increasing focus on broadly neutralizing antibodies. These are some researchers going on this, and they are giving out the promising figures. Condoms we have seen they are accessible and they are fundamental for HIV and STI prevention together. We also have in the markets, we have microbiicides, which is a critical option to expand choice. They are being used in some settings. Then we have the cure. The role of cure in controlling and ending the epidemic is in the pipeline. So maybe in the near future, we might end up with a cure. And then we have the other multipurpose prevention technologies, which address more than one sexual and reproductive health concern. We have the HIV prevention product overview, and we are saying we have the oral PrEP, which is being used, and it has shown to work to prevent the HIV. And we have the dosages there on how to use it. And this one is quite promising. Say, although the uptake in the country is a bit low. We have the dapivirine vaginal ring, which is also used to prevent HIV. And this one, from the moment it was rolled out, I think we, as a country, have not done well on this because the supplies on these are still low, and most women are not even aware about it. We also have the injectable capnography, Kabili, which is as an injection, which is injected in day 1, then month 1, month 3, and month 5, all throughout. This is a form of injectable for preventing HIV, and which is there in the country, but in the general population rollout, it has not succeeded as such. So we still have a long way to go. We have the new one which is being rolled out by the WHO. It's called the lenacapavir, or the LEN. This is the newest HIV infection injection, and it has been shown to work. I think it was in the second trial, and the Gilead and the other manufacturing and the research has shown it is quite effective to prevent HIV, and is being injected after every 6 months, and we're hoping this one will be available in our country maybe probably early next year, as promised by the Ministry of Health. And we still have other developers coming up with the new methods. So we expect by next year the rollout with some of these, and there are companies which are doing the cost effectiveness to make sure these drugs are available to the resource limited countries, so that the general population can be able to afford. So this is the journey for the new product, the LEN, which we started with the year 1. And it has been used in the trials, and it is promising that be seen by within 1 year it is effective. So it is preventing HIV infection less than a year. Year 2, we had the injectable Kabili, and these drugs have been, their efficacy results, they are shown there, because we had the first regulator approval occurring at that times. Then the WHO recommended most of them to be used. And the green one showed the first African regulatory approval, the time it happened. And you can see it is happening quite late, more than 18 months for all of them. Some have taken 5 years, and maybe that's why the prevention methods have not been able to take up. Next. So we need to increase awareness of PrEP and normalize it as a prevention option among potential users, including through social media outreach programs so that PrEP can be made available in more flexible and convenient ways, even through the community drop-in centers, can have mobile clinics and the pharmacies. Then we have the multi-tooth dispensing, where we can use the virtual services platforms. And also maybe we review our laws of parental consent for young girls and boys, and encourage large roles for community-led organizations so that we can drive the agenda for PrEP and decrease its use among the youth and adolescents. The PrEP screening and initiation here in the hospital, since we started rolling out the PrEP, and mostly here what we usually offer is the oral PrEP. We don't have the injectable. We don't have the Kabili, which is a 3-month injection. It has not yet been, as I mentioned earlier, been available across most populations in the country. So in 2024, we are able to screen the numbers shown on the screen. And the ones who are eligible for PrEP were a bit low, that is almost 2,000. The ones who were eligible and willing to use PrEP, they were also very few, 216, which gives us a percentage of 11%. The ones who were initiated on the PrEP in that first quarter were 6 of them. So from this, we can see, although going forward in the year, the numbers kept it on increasing. But this one shows us we need to continue creating awareness and be able to show the people who are at risk, especially if people are eligible and willing, they are eligible for PrEP, and they are at high risk, they should be encouraged to adopt the PrEP for prevention purposes. But we should not forget about our usual methods, condoms, which have been with us, and with the funding of the programs, the demand creation has gone down. So we need to still emphasize and advocate for our governments to make the condoms more available to our populations, the ones who are at risk. And as a result, new generation of young people, some of them, they're even lacking adequate information about and the access of condoms. So we need to go back and create awareness. I've also mentioned about male medical circumcision, which also reduces acquisition of HIV by 60%. So we need to encourage the populations who don't encourage this method, who don't circumcise, to adopt circumcision as a way of preventing HIV. So it is cost effective, as I said earlier. Although the uptake in Kenya has generally not been fully realized, so we need to create awareness a lot. Especially most of these programs were donor funded. So as the donor funding squeezes, we need to integrate it to other services across the hospital and other service delivery points. The prevention through antiretroviral medicine for HIV prevention. Earlier we said U is equal to U, and we encourage the people who have been diagnosed newly positive, HIV positive, to be put on antiviral treatment and encourage them on adherence. so that they're able to get viral suppression. And as we said earlier, if clients are virally suppressed, the chances of spreading HIV is minimal. So we know today the majority of people living with HIV who are aware of their HIV positive status are taking their treatment as prescribed and are not at the risk of transmitting HIV sexually. And this one has been shown in our antenatal and the postnatal care of women, where most babies are being born without HIV. So we need to encourage adherence, especially to our adolescent youth, to adhere to treatment. So as we wind up, we are saying 1 in 8 people said they had never told anyone about their HIV status other than healthcare professionals. So we need to encourage people to do disclosure very early. And 1 in 5 people needed help with loneliness and isolation in the past year. This is very true because HIV causes mental health issues. So we need to encourage people to not and this is mostly because of stigma. So we need to deal a lot with the stigma in those people. And the 1 in 10 had actually been denied or refused health treatment or procedure that they needed. This is also because of stigma. There are people who still stigmatize the people who are HIV positive, and they are denied most of the services as they reported. And the 1 in 3 is worried that they would be treated differently to other patients. This is self-stigma, and we need to encourage the ones who are newly being diagnosed to open up so that they don't feel they will be stigmatized by others. So we are saying HIV stays in the body for life, but treatment can keep the virus under control and the immune system's health. Without medication, people with HIV, we are saying they will transit to AIDS. And the treatment is effective and it reduces the viral load to undetectable levels within 6 months. And thus it will maintain a healthy and ensure somebody lives a healthy life. And we should all do this through people-centered approach. Although we know there are treatment gaps, and the aim is to ensure that everyone living with HIV is diagnosed, and we should encourage people to keep on testing. And because nowadays we still have the self-test. In the hospital, we have test kits where somebody can test himself for those who fear to be seen testing in the health facilities. So the treatment gap is still there between men and the women, and we need to cross that treatment gap by breaking the cycles of transmission. If more people living with HIV know their HIV positive status, start and stay on ARVs, they will be able to and reach sustainable viral suppression. Then their sexual partners are likely to get HIV virus. So as we wind up, effective treatment for HIV suppresses the virus, as we have said. And we also need to remind ourselves and our community, HIV cannot be passed on through day-to-day conduct. It cannot be passed through things like touching, kissing, sharing, cutlery, or glasses. HIV can be passed on through sex without a condom, but only if a person is not on an effective treatment. It can be passed on through sharing of needles and and during pregnancy. So we need to take care. Some groups of people are affected by HIV more than others, but it can be passed on to anyone. That's what we should remember. People living with HIV can live long and healthy lives. I think that I've talked about that. So we need to just to encourage them to be on treatment. Getting regularly tested for HIV if you are sexually active. This is very important. When you are sexually active and you are not using the protective methods we have talked about, then you need to have regular testing for HIV. And we have said taking PrEP or PEP tablets which prevent HIV, either before or just after you have been exposed to it, you can prevent HIV. And using condoms. For those who inject drugs, you should not share the needles. They should be encouraged not to share the needles. And those who are on treatment, they should be encouraged to take their medication regularly. So as we wind up, in the KNH VCT and HIV prevention unit, we bring together all staff in the hospital in HIV matters, policymakers, and other important stakeholders, so that we're able to develop the rights and the secure lasting change in our community as a hospital. We do a lot of research and make resources and then recommendations on the way we can improve in HIV prevention. We also champion the voices of those who are underrepresented, especially the clients in our clinics. And we are saying we are not afraid to hold the powerful to count, the power to account. You can reach us at KNH VCT as we work to stop HIV from standing in the way of health, dignity and equality, and to end new HIV transmissions. Our expertise, research, and advocacy secures a lasting change to the lives of people living with and at the risk of HIV. You can support us through this work during this World AIDS Day and beyond. Let's challenge HIV stigma as we have seen. Let's create awareness for HIV activities across the hospital and in the community. You join our work in fighting HIV, in advocacy, and you can share our HIV experience successes as we have seen the people we are put on PrEP. We are almost testing every client stroke patient in our facility through their consent, and we are putting many to care as we have seen. So let's encourage this work. And with that, I say thank you. Now I invite Carol just to tell us a bit about adolescents. And if there are questions, we allow the questions for the people online.
So good afternoon, colleagues. Just to support the theme of the World AIDS Day this year, one of the major activities was to end the teenage pregnancies, and we thought it wise that for us to share what has been our experience at the youth center. So sorry for the technical hiccup. So teenage pregnancies are usually contributed by a number of factors, which are not limited to the ones that I have listed below. And these include low education, limited knowledge to SRH, that is sexual reproductive health, coupled with inadequate parental or societal involvement in their guidance and the protection of the adolescent. And this one is something that we have really found even among the school-going young people. The other factor is poverty and associated vulnerabilities. There's also early sexual debut, owing probably to financial issues. There's marriage among the young people or among the children, which has which has contributed to a number of the teenage pregnancies that we find at our labor ward. Gender-based violence is one of the commonest factor among the teenagers, because we know even below 18, we do not call it rape. It is actually defilement because there's more of coercion or even being threatened. And then the last factor is inadequate access to friendly and responsive sexual reproductive health services by the adolescent. This one has played a major role because you find them out of naivety, out of just experimenting, they may find themselves being pregnant. So at the youth center, we find the cases that we've been called to attend to, especially in labor or antenatal postnatal wards, will be young people out of early marriages, especially because we are near Kajiado. So we find them coming in with complications, and the major complication being eclampsia and preeclampsia, and even the complications of HELLP syndrome. Then we find them experimenting amongst themselves. This one is usually at times driven by peer pressure. And there's also been the fact that the girls have also been the ones pushing the agenda. Am I audible? Am I audible? Okay, thank you. Thank you for the feedback. The other experience that we've had at the youth center, as I had earlier said, there's lack of adequate and accurate reproductive health information. And most of them will be coming in with myths and misconceptions, which we play a major role in trying to decipher and giving them the appropriate information. We have gender-based violence, which is very common, and at times, even within the family setup, whereby we find it could be even a brother who has sexually violated a girl and has ended up being pregnant. We have the other experience being lack of access to contraceptives. This one I'll talk about more so to the ones heading to campuses, the 18 or 19-year-olds who are new freshers. They get young men there who are already seasoned and they know how to play them, and then they find themselves not unable to access contraceptives and they find themselves pregnant. So the effects of teenage pregnancy, the few that we have seen would be anemia, which will be associated in the pregnancy. They'll come with stillbirths, with eclampsia, which is the major occurrence in our setup. But they also have preterm births and low birth weights. There's discontinuation of the school, especially for the girls, because they're the carrier of the outcome. And then the boys usually continue with their school. this low self-esteem that can even at times lead to cases of depression. And then there's also a bit of discrimination by the peers and even the society, because a mother may not want her daughter to associate with a girl who is already pregnant while in school. So what are the preventive measures that we can use? The first one, appropriate age-appropriate sex education. And I find this being something that a lot of us do not concur with. However, you'll find with the cases that are there, if you don't give the information will be given by somebody else. And we're not telling you to tell them exactly what happens, but just age-appropriate sex education, telling them what is private, what needs not to be touched, and just even telling them what to do should they find themselves in such a scenario. That means screaming or running away from the perpetrator. Health education on post-rape care to school-going children, and even self-protection strategies. A lot of young girls undergo rape, and they do not have the confidence in telling anyone. And when they're in high school, they end up having behavioral issues. And when we get into the rooms, we are finding out a majority of them may have gone through sexual assault while they were young and were not able to tell anyone. And this goes for both genders, that is male and female, and you find it, it expresses itself in behavior while in high school. As I said, self-protection strategies whereby you're able to tell the young person, what should you do should you find yourself in a situation where somebody is trying to coerce you or lure you into such a situation. Or even to rooms, it could be into a car, or even friends telling you to go to their places to visit them. And then intentional parenting, 95% at times, or 80%, I would say, we find our parents are busy trying to make a living and a better living for their young children. And so they miss out a lot. And you'll find by the time the person is getting to adolescence, the mother is saying, simuelewi, hanielewi. So if you're intentional, whereby you're having conversations flowing, then it is easier for you to be able to give them advice before they get advice out there. So if you do not become the first people to give the information, it will be available on the social media. It will be available from the young people, which will be quite misleading. And we know even in the social media, not all information is correct information. And then another preventive measure would be providing youth-friendly spaces for accessing reproductive health information, as well as probably contraceptives. And I'm not saying this for the young people who are school going, but once they get into campus, you may find that you may not have a control of what they do, but in high school, probably we could. So the role of the youth center, KNH is a pro-life, hence supportive. We provide supportive psychosocial support throughout pregnancy. And what we have found is that when I say we are pro-life, that means we do not terminate, but we support the young people, and we always give them the option of adoption. So when the young girl comes, we tell the girl we can support her through pregnancy, and once the baby is born, then the baby can be given up for adoption. That is what we usually do through the social worker and through the child welfare department within our county. Then we also do supportive disclosure to the client support system. That means the parents, because at times, most of the time, the young person is afraid of how the mother may react or what they may do. And so we have found, even with the many that have come with an intention of wanting to terminate, by the time we are doing this, what we call supportive disclosure, is that they have ended up getting the babies and going back home. Probably one in many whereby the girl really wanted the baby, but the mother did not want, but she ended up with the baby at home. Psychological support in cases of SGBV, that is something we usually do after the acute case, probably to say when the case is acute, that means the patient walks in when it is less than 72 hours after the assault. They usually go to A&E, or what we would call emergency medical care center, or the ITC, the International Trauma, and whereby we have a room there called Tumaini Center. In the Tumaini Center, there is a person who receives them, and they are taken through the gynae room, whereby every specimen is taken, which is very important in case they are going to take the case to the police. They must have come from the police, whereby they have already filled in an OB. So the doctor fills in the PRC form, which is very useful when it comes to the legal issues. Then the specimen is usually collected by the policemen from the place that they had reported from to our national labs, and then they are used later in court. So subsequently, and then they are given the essential, the critical care, whereby they are given, they are started on PEP. They will be given, they will be tested for pregnancy. If none, then they will be getting the E-pill to avoid getting pregnant. And then we also do STI management, and we put the patient on treatment. And then continuous support is given through the youth center with the age between 13 to 24, but beyond 24, then they go to mental health and they find a team there. So that is the care for the GBV within our setup. And then in case that they need any legal issues, then they have to pass through the legal office to get a clearance, and then they can get a report that is usually availed into the courts. Then the other role of the youth center is providing reproductive health information, because as we have said, you'll find that a lot that is what is said on the social media could be just people writing their own things. So we usually give accurate and evidence-based information. And then also the information about post-rape care, contraceptive use. And for a very long time, they've been able to access contraceptives within our unit. However, because of the finances, now it has become a bit of a challenge. But we still give the counseling. We do contraceptive use counseling, and then we direct them we work together with Clinic 66. Life skills training, whereby we train the young people with assertiveness, critical thinking, and decision making, because we know the young people, as they are growing, their brains are also developing. They are also developing, because full development of the brain completes at the age of about 23, 24, and 25. So you'll find by teenage years, they are still making irrational thoughts, because the frontal region is still developing. So we also do that, just to make sure that they are able to have the skills that they require. Then the last role that we usually do, we also help them to adjust back to school. Now, because they have come in and they have gotten a baby, it doesn't mean that's the end of life. So how do they report back to school? And that is our role, whereby we also work with the support system. That means the parents and the relatives of the young person. So that is the end of my presentation. Thank you so much. You're free to ask any question as we take a look at the ones that are there for us to be able to answer.
Yes, I wish to answer the long-acting injectables PrEP, they are available in Kenya, but mostly they are under program. And right now, as I said earlier, the 3-month injection is still there, but not in high supplies. The supplies are very low. And even in the Kenyatta National Hospital, we don't have it. So we are longing for the government to accelerate the availability of the drug. I hope you have answered the question. Then Abkarim Osman, the strategy for prevention for people with HIV, yes, we have the counseling, psychosocial support, and we have the groups, the support groups where they meet for treatment and encouragement, and We also have the support group, the clinicians, where we look at the opportunistic infections like TB, which we screened, and then they are put on treatment as the situation arises. With the rate of discontent couples in our clinics, they are not quite many, but they are few. It's almost either 1%. We don't get many of the discontent couples with us. Anonymous, this forum can help us to understand for those who are not willing to use the condoms and the rest. You can only get protected when you take PrEP. Please utilize what is available in our country. We have the oral PrEP, which is free in our health facilities. So please get in touch with them. Yes, you'll be able to upload your CBD. We'll send you the code. The vaccines, I said they are not with us, but this is our future discussion, and we know many trials and the studies are on, and the researches are ongoing. The disclosure in our facility is quite comprehensive for families. There's a guideline which we use to do the disclosure. Mostly we invite the couples and we individually, and then there's a couple to do the disclosure. The mothers who are positive, nowadays we don't discourage them from breastfeeding. I think initially it used to happen, but nowadays, because these mothers are on treatment, and the chances of passing the virus to their babies is quite low. So there are those, if they want to breastfeed, we give them that chance. Sharing the presentation there, we have to look at that because we are guided also by the hospital rules and the regulations. The PrEP injection, we are saying starting this year or Monday, maybe probably by February, if it goes well with our government, it should be in the country. Edward Karebo, the stigma is just, as I mentioned earlier, is to let the people open up for themselves, because the stigma is quite hard to fight, but we can try. If we encourage the clients to open up and share their issues with the counselors and even to the public, so that we end the stigma, and also sensitize people, the ones who handle these positive clients, just to be compassionate enough and have empathy on them and sympathize with them and not talking bad things about them. The regimen for PrEP, I think I shared it earlier in the presentation, but for more details, you can visit us. We'll give you more information. HIV circumcision has been proven through the research. These are scientific proven methods. So the data from the researchers has informed us it works. I think that one anonymous, the CBD code will be shared. HIV vaccine trials in Kenya is ongoing. I think we still don't have any report by now. Our pharmaceutical, this is big, encourage the pharmaceuticals locally to manufacture some of these drugs with the agreement from the major unique companies. So the generics very soon will be locally available. Yes, Gen Gore PrEP is given to the disconduct couples after taking them through, so that the one who is negative is put on PrEP, the one who is positive is started on treatment. And also the condom is a combination prevention which continues. For physiotherapy to get the CPD points in the future, I think that we will consider that. Thank you. I think I've answered most of the questions raised. We still have time. Thank you, Edward Karebo, for your input. And with that, I think.
So we wish to thank all of you who have joined. We see the numbers were quite great. We really appreciate that, and we hope that at least as we go home, everyone has picked something to think about and some new information about HIV, which we have been trying to manage for the many years. So thank you. Hope to see you again. Thank you.
Thank you all, and we wish you a good evening.